Group 13 presented a video summary based on an article titled Machine Learning to Predict ICU Admission, ICU Mortality, and Survivor's Length of Stay Among COVID-19 Patients toward Optimal Allocation of ICU Resources. This study aims to identify variables and test the accuracy to predict the need for ICU admission, death despite ICU care, and among survivors, length of ICU stay before patients were admitted to ICU. This study is done based on 3 open questions. First, who needs to be admitted to ICU and what risk factors contribute to this? Second, who will die despite being admitted to ICU? Third, among those admitted to ICU and later discharged alive, can machine learning predict their length of ICU stay? Among all inpatients, the model aimed to predict who needs to be admitted into ICU. Among patients admitted to ICU, the model aimed to predict who would unfortunately die. And among survivors in ICU, the model aimed to predict the length of stay in the ICU. This study collects retrospective data from 733 inpatients confirmed of COVID-19 in Huapi Hospital of Traditional Chinese Medicine, Wuhan, China. Diagnostic methods were based on positive real-time reverse transcriptase polymerase chain reaction (RT-PCR-AC) for nasal and pharyngeal swab specimens, or the existence of immunoglobulin M and immunoglobulin G antibodies. 909 variables were extracted as potential predictive variables. These 909 variables came from 3 categories. First, demographic information, including sex, age, and presence or absence of comorbidities. Second, clinical and course examinations include chest radiography or CT scan, main symptoms at admission, and daily routine tests. Third is laboratory indicators. First target variable is from need or no need for ICU. About 25 patients are actually admitted into ICU and underwent invasive ventilation, plus 8 patients who died of COVID-19 despite never being admitted into ICU due to a shortage of ICU resources. The no need for ICU group included 700 patients who were not admitted into ICU and were later healed. Second target variable is ICU outcome, which is either death or survival. The ICU death group had 8 patients and ICU survival group had 17 patients. Last target variable is length of ICU stay among survivals. 14 survivals stayed in ICU for 6 ± 2 days. Moving on to the results for this study. Most patients in need for ICU were above 50 years of age. Of the patient admitted into ICU, death happened in 5% of patients in the 25 to 49 years age group, 14% of patients in the 50 to 64 years age group, and 80% of patients in the above 65 years age group. Comorbidities existed in 222 patients including diabetes, hypertension, hyperlipidemia, cerebral infarction, hepatorenal insufficiency, and heart disease. Based on the table, 10 clinical variables achieved the highest AUC predicting a patient's need for ICU admissions. They were the mean of oxygen saturation, AUC of 0.95, mean of high sensitivity troponin 1, AUC 0.94, mean of myoglobulin of AUC of 0.92, mean of albumin, AUC of 0.87, mean of lactate dehydrogenase of AUC of 0.87, variance of high sensitivity troponin 1, AUC of 0.85, variance of myoglobulin, AUC 0.85, mean of D-dimer, AUC of 0.84, mean of lymphocyte percentage, AUC of 0.83, and the mean of lymphocyte absolute value, AUC of 0.83. Based on the box plot, the need for ICU and no need for ICU groups had significant difference values in these variables. The table lists the top 10 clinical variables that, when considered alone, best predict death in ICU. They were the mean of lymphocyte percentage of AUC of 0.97, mean of lymphocyte absolute value AUC of 0.96, mean of lactate dehydrogenase AUC of 0.89, mean of D-dimer AUC of 0.88, mean of albumin AUC of 0.83, mean of adenosine deaminase AUC of 0.78, variance of lactate dehydrogenase AUC of 0.76, variance of direct bilirubin AUC of 0.62, variance of respiratory rate AUC of 0.58, variance of the pulse AUC of 0.52. Their corresponding box plots with respect to the two types of patients indicate LP, LAV, and D-dimer to be statistically different. A patient admitted into ICU was most likely to die with a low LP, low LAV, lower albumin, higher LDH, higher D-dimer, larger fluctuation of ADA, larger fluctuation of RR, larger fluctuation of DBIL, and larger fluctuation of the pulse. The table shows that the top 10 clinical variables most predictive of length of ICU stay among survivors were the mean of lymphocyte absolute value of MAE of 1.91 days, mean of erythrocyte count of MAE of 1.68 days, mean of total cholesterol of MAE of 2.22 days, adenovirus IgM antibody of MAE of 2.25 days, mean of hypersensitivity corrective protein of MAE of 2.04 days, the variance of high sensitivity troponin 1 of MAE of 1.92 days, the variance of total cholesterol of MAE of 2.12 days, Q fever rickettsia IgM antibody of MAE of 2.01 days, heart disease of MAE of 1234 days, and age of MAE of 1.72 days. If the patient was older and suffered from heart disease, the longer they stayed in the ICU, as well as the abnormal values for LAV, RBC, TCHO, high sensitivity troponin 1, hypersensitive corrective protein, Q fever IgM, and adenovirus IgM affected the length of stay in the ICU. This proactive approach focuses on predicting the need for ICU admission 1 to 15 days in advance, which can significantly help hospitals manage their resources more effectively. By using the top 10 clinical variables, the prediction model achieved an AUC area under the curve of 0.8429, indicating high accuracy. Key predictors included oxygen saturation with an AUC of 0.948, high sensitive troponin 1 with an AUC of 0.936, and myoglobulin with an AUC of 0.924. Specific threshold identified were oxygen saturation level below 88%, high sensitivity troponin 1 levels above 20.3 picometer per milligram, and myoglobulin level below 51.55 nanogram per milliliter. The studies also identified key predictors for mortality in ICU patients. These included lymphocyte percentage, lymphocyte absolute value, lactate dehydrogenase, D-dimer, albumin, adenosine deaminase, direct bilirubin, respiratory rate, and pulse. Notably, a D-dimer value greater than 5.41 microgram per milliliter indicates a high risk of coagulation disorder such as pulmonary embolism, while factors like LDH, DB, and others indicates organ damage and immune system impairment. Additionally, the study focused on predicting the length of ICU stay among survivors. Key predictors for a longer ICU stay included older age, which is over 60 years old, heart disease, and higher total cholesterol, possibly indicating hyperlipidemia, which can complicate recovery. In conclusion, machine learning could predict which patient with COVID-19 needs ICU admission and which patients would unfortunately still die even admitted to ICU, and among survivors, the length of ICU stay. All predictions were achieved 1 to 15 days before the patient were actually admitted to ICU. The high predictive power provides a quantitative reference to better plan and allocates ICU resources. That's all from us. Thank you.